Obstetric history and examination. First, the patient details, in which we should ask for the general information like history of current pregnancy, past obstetric history, gynecological histories, inquiry about other systems, past medical and surgical history, psychiatric history, family history, social history, drug history, history of allergies, and finally the summary of the history. Information, in which we need to ask the name of the patient, is the marital status, occupation. Occupation is very important because that gives us an idea about the educational background as well as the socioeconomic status of the patient. Then the presenting complaint. It should be in patient's own words, and it is preferable not to use medical terms. Or we should ask the main reason for attending the hospital. That should be included in the presenting complaint. Then gravidity. It is a total number of pregnancies regardless of their end result. Parity. It is a number of live births at any gestation or stillbirths after 28 weeks of gestation. Moving with the general information, we have to know the gestational age, then we need to know the last menstrual period, then we have to calculate the expected date of delivery and we apply Naegele's rule to that. In short, expected date of delivery is also known as EDD. So the Naegele's rule is to add 9 months and 7 days to the first day of the last normal menstrual period. For example, if the lady had LMP on 1st of May 2020, her EDD will be 7th of February 2021. Average cycle of a normal menstrual cycle will be 28 days, but it can range from 21 to 35 days. So if it is 21, add 1 day, and if it is 20-day cycle, add 7 days, and if it is 35-day cycle, add 14 days in order to get EDD. Now the history of current pregnancy. Dates as calculated from ultrasound if lady is not sure of her LMP. So we should take the first trimester scan or the dating scan to confirm her EDD. If she has had an ultrasound, we should also see whether it's a single pregnancy or whether it's a multiple pregnancy. If it's multiple pregnancy, we need to determine what is the chorionicity of the gestation, because first trimester scan is best for seeing the chorionicity. Then we should have the details of the presenting problems, like, for example, whether she has bleeding per vaginum, whether she is having excessive discharge per vaginum, whether she has urinary tract infection, or any other problems like excessive vomiting, etc. So, these are the things that we need to ask in her history of current pregnancy. Past obstetric history is very important. So, we need to know when was her last date of delivery or pregnancy termination. Where did she have the delivery? Was it a hospital delivery or was it a home delivery? We need to know the site of the pregnancy termination. Then we need to know what type of delivery she had or the method of termination of pregnancy. This information is very important for planning the method of delivery in the present pregnancy. Like if she had a vaginal delivery, but if it had been difficult, and if she had a 3rd-degree perineal tear, or if she had a 4th-degree perineal tear, then it's better not to venture into vaginal delivery this time. Better to go for cesarean section. Similarly, if she had cesarean section before, then we have to think about induction, how we are going to induce her, because induction with prostaglandins might be dangerous and it requires a very vigilant environment. Hence, we have to know what type of delivery she had in the previous pregnancy. Then the duration of gestation. Was it a term pregnancy or was it a preterm pregnancy? Because if she had a preterm pregnancy before, the chances of having preterm pregnancy in this pregnancy is higher. Hence, we need to know the duration of gestation, and it's preferable if it is recorded in weeks, even if the patient says that in months. We need to know the birth weight of the baby because this gives us an idea about the assessment of fetal growth patterns. Like, for example, if she said, I had a term delivery, but the birth weight of my baby was only 1.5 kgs. So that gives us an idea that this might be a fetus with IUGR, and the chances of having IUGR in this pregnancy becomes higher, and we can prevent it if we know if she had such kind of history in the previous pregnancy. Then we should know the gestational age if she had any spontaneous abortion, because the causes of abortion varies according to the period of gestation. If it had been a first trimester spontaneous abortion, then we should think about chromosomal anomalies in the fetus, or if she had Abha syndrome or some genetic problems. If it had been a spontaneous, painless, spontaneous abortion in the second trimester, then the first thing that comes to our mind is cervical incompetence. Hence, it's very important to know the gestational age at which spontaneous abortion occurred. Then we should ask her about the duration of labor in a previous pregnancy, because this gives us an idea of an unusually long or short labor. If she said, I had pain and I delivered within 1 hour of the pain, then that suggests that she might have had a precipitate labor. But if she said, I went into labor and then I delivered after 3 days, that means it's an unusually long labor. So we should think about whether it was a deflexed head or whether she had some problems following the delivery. So these are the things we need to know and when we ask about the duration of labor. If she had cesarean section, we should know the indication for the surgery. And what type of anesthesia did she get? Because if it had been an elective surgery, most of the time it will be done under spinal anesthesia. But if it had been an emergency surgery, like if she was bleeding profusely, like antepartum hemorrhage, then most of the time we go for general anesthesia. And we should also ask for any complication of anesthesia if she had in the previous pregnancy. We are continuing with the past obstetric history. We should ask about complications in the past obstetric history, like urinary tract infection, whether she had vaginal bleeding, whether there was hypertension for which she was treated, whether she was given any drugs for that, whether she had gestational diabetes in a previous pregnancy. If so, was she treated with insulin or was she given oral hypoglycemic agent? Then we should also ask about postpartum complications because these complications may repeat in this pregnancy. Hence, it is very helpful in anticipating and preventing problems with the present pregnancy. Next thing is the newborn weight. It might be either in grams, pounds, or ounces. This information gives us an indication that if the baby had been very big or macrosomic, this suggests that she might have a gestational diabetes in the previous pregnancy. But if she says my baby's weight was only 1 kg, then it might suggest that it might have been an IUGR. And we should also ask whether the baby was stuck, whether the baby has problem with the shoulder, with the hands, because that gives us an idea if there had been a shoulder dystocia in the previous pregnancy. or cephalopelvic disproportion. We need to know the gender of the newborn because it indicates that there are certain genetic risk factors which might prevail if she had problems in the previous pregnancy. We should ask about the fetal and the neonatal complications. An inquiry should be made as to whether the baby had any problems after it was born. Did it cry immediately after the birth? And whether the baby was in ICU, NICU. Was the baby discharged along with the mother? So this gives us a fair idea as to whether the baby had any problems or not. And we should also ask, how is the baby doing at present? So these are the things we should know in past obstetric history. Coming to the gynecological history, we should ask about last menstrual period. We should ask for the regularity of the cycles, especially the previous 3 cycles. If she says, my previous 3 cycles are very regular, then that indicates that she is ovulating well and there should be no problem with calculating EDD by LMP. Then the other history is contraceptive history. If she was using any form of contraception, then we should ask her what contraception was she using prior to her pregnancy, or was she on contraceptives and this pregnancy is due to failure of contraceptives. Like if she's on oral contraceptives or whether it's an IU intrauterine contraceptive devices, because a retained intrauterine contraceptive device can cause pregnancy loss, infections, and even premature delivery. We should ask about previous history of infections like PID, vaginitis, or cervicitis and the treatment, and whether her partner was treated or not. Has she ever taken a cervical smear? If so, when was the last cervical smear taken? And what was the result? Was it normal or abnormal? If it was abnormal, what was the treatment taken then? And we should also ask about previous gynecological surgeries like oophorectomy, cystectomy, myomectomy, hysterotomy, because this is very important to plan how to proceed with the present pregnancy. Past medical and surgical history. We have to know the relevant medical problems and the drug history. Disorders like diabetes mellitus, hypertension, renal diseases, which are known to affect the pregnancy outcome, should be noted. We should also ask about any previous operations and the type of anesthesia given, and if she had any complications, that should be noted. Each surgical procedure should be recorded chronologically, including the date, hospital, and complications if she had any. We should also ask for history of trauma and it must be listed. For example, fractured pelvis may result in diminished pelvic capacity. Psychiatric history is very important. When we take obstetric history, we should ask about history of postpartum blues or depression in previous pregnancy or in the postpartum period, and depression unrelated to pregnancy or any major psychiatric illnesses that she has or for which she is taking any medications. Then we should go for family history like history of diabetes in the first degree relative, history of hypertension, history of thromboembolic diseases, genetic problems, and also thyroid disorder. In social history, we should ask the history of smoking. If she is a smoker, we should ask how many cigarettes does she consume per day. Then history of alcohol use and illegal drug uses. We should ask for exposure to domestic animals, particularly cats, because it carries a risk for toxoplasmosis. We should ask for history of exposure to radiation in early pregnancy, history of pelvic X-ray or CT scan. Sexual history. We should ask about the health of and current relationship with the husband or the partners, and it provides an insight into the present complaint. We should also inquire about any pain like this periunia, bleeding, or dysuria associated with sexual intercourse. History of drug intake like antipsychotic drugs, anti-epileptic drugs, steroids, etc. Because these are the drugs which can have a bad implication in the fetus in this pregnancy. If she is taking, then whether she was continuing when she conceived or has she left it. So these are the things that we should know in the history of drug intake. Then history of allergies to any drugs, like if she's allergic to penicillin or whether she's allergic to ciprofloxacin or whether she is allergic to paracetamol, this kind of history should be taken. Or history of allergy to things or food. And in the end, we should summarize the history. Now, after the history, we come to the obstetric physical examination. First of all, the general examination, then the abdominal examination, lower limb examination, pelvic examination, breast examination, and thyroid examination are a must when we examine a pregnant lady. In general examination, we see the weight, the height, BMI, the formula of which is weight in kgs divided by height in meter square. We should monitor the vital signs, which includes blood pressure, pulse rate, respiratory rate, and temperature. We should go for cardiovascular examination. Routine auscultation of maternal heart sound is very important, and if there is any diastolic murmur, it is pathological. In breast examination, we need to especially see for mass in the breast or if there is any discharge from the nipples. And in the nipples, we need to look whether it's inverted nipples or flat nipples. And in thyroid examination, we need to see if there is any mass or nodules in the thyroid. If it is there, then it should be noted. When we examine the abdomen, we should always stand on the right side of the patient to facilitate the movement of the right arm. Male doctors should have a lady companion or lady nurse while examining a lady patient in order to prevent medical legal issues. Examination should be done by the palm of the hand rather than the tip of the fingers, and it is good if we have warm hands before palpating the abdomen. When we are examining the abdomen, it is good to talk to the patient and we should look at their face for sign of pain like wincing. Examine the inguinal canal for inguinal hernias and inguinal lymph nodes while examining the abdomen. Position and exposure while doing an abdominal examination. The patient lies flat with slightly raised head on a pillow. Her knees are drawn up to decrease the rigidity of the abdominal wall. The abdominal wall is divided into 9 quadrants by 2 vertical lines. Mid-clavicular plane, which extends from the mid-clavicular region to the mid-inguinal region, and 2 horizontal lines. The upper horizontal line, that is transpyloric plane at the level of the first lumbar vertebra, bisects the distance between the umbilicus and the xiphisternum, and the lower horizontal line, that is the intercrestal plane, which extends between the highest point and the iliac crest. This division is very important to know because if we see any mass or if there is any kind of scar, then we can note it correctly, giving a definite name. Continuing with abdominal examination, prior to the palpation, we should ask the patient for the areas of tenderness. And when palpating, we should come to that area last. Before that, we should inspect the abdomen. We should inspect the abdomen for its contour, look for the asymmetry. In a pregnant woman, if there is an asymmetry, it might suggest a subsidorsal fibroid or a bicornuate uterus or unicornuate uterus. Then we should look for The movement of the abdomen with the respiration, whether it moves equally with respiration or not. We should look for fetal movement. Then we should also examine and see and inspect whether there are any scars of previous operations in the abdomen. We should note the pigmentation or the cutaneous signs of pregnancy like linea nigra, stria gravidarum, or linea albicans. Look for the umbilicus. See where it is, the site, the shape, whether it's inverted, whether it's flat, or whether it's everted, whether there is any discharge coming from the umbilicus, whether there is any discoloration, whether there's a swelling or a nodule. These are important things we should note on inspection of the abdomen. Also note for the hair distribution. The feminine pattern of hair distribution will be triangular with horizontal upper border, and a masculine type of hair distribution will be extension of the pubic hair towards the umbilicus. Hernial orifices should be examined. We should see for cough impulse. Ask the patient to cough and look at the hernial orifices like umbilical region, paraumbilical region, inguinal, and also look for incisional hernia if she has a scar. When we palpate, see for divarication of recti. Then we should think about the causes of abdominal enlargement like fetus, false pregnancy, ovarian tumor, fat, full bladder, fluid, or fibroid. When we palpate a gravid uterus, we should see for the uterine size. The symphysiofundal height should be measured in centimeter, and it is done by a measuring tape. And it should correspond to the period of gestation in weeks. When the uterus is 12 to 14 weeks, it will be just palpable, as shown in the figure. It will just be palpable above the symphysis pubis. At 20 to 22 weeks of gestation, it will be at the level of the umbilicus, and when it is 24 to 26 weeks, it will be above the umbilicus, and at 28 weeks, it will be in between the umbilicus and the xiphisternum, and it will be at the level of xiphisternum at 36 weeks of gestation. And when it is term, there will be lightening and it slightly comes down and it will be at the level of 34 to 36 week size. Now the Leopold's maneuver. The first maneuver, also known as the fundal grip. This involves palpating the fundus to determine which part of the fetus occupies the fundus. It is done by grasping the fundus of the uterus by the palms of the two hands with our fingers quite close together. This gives us an idea whether it is a longitudinal lie or whether it's transverse lie. What is there in the fundus? If it's a broad mass which is soft, it suggests that it's a breech, and that suggests that it's a cephalic presentation. Whereas if we can feel a hard palatable mass in the fundus, then that suggests that even though the baby has a longitudinal lie, it is breech. The second maneuver is lateral grip. It involves palpating the either side of the abdomen to determine on which side the fetal back lies. Because when we auscultate, we need to know where the fetal back lies. The third maneuver is the Paulick's grip. It involves grasping the presenting part between the thumb and the fingers just above the pubic symphysis to determine what fetal part is lying above the pelvic inlet or in the lower uterine segment. Suppose if it is a hard palatable mass, then that is a fetal head. But if it is a soft broad mass, then that suggests that it's a fetal breech. And if it is empty, then it suggests that it might be a transverse lie. Fourth grip, or the fourth maneuver, the pelvic grip, it involves palpating for the brow and the occiput of the fetus. And this determines the fetal position when the fetus is in vertex presentation. And it will also give us an idea whether the fetal head is engaged or not. The descent of the fetal head is assessed abdominally using the rule of fifth to assess the engagement. Assess how much of the head is felt per abdomen. When only 2/5 or less of the fetal head is palpated above the level of symphysis pubis, this implies that the head is engaged and the vertex has passed or is at the level of the ischial spines. We should auscultate and listen for the fetal heart sound for 1 minute. We can auscultate either by stethoscope or a fetoscope, or we can even do it by Doppler. Should assess the lower limbs and see for any swelling or varicosities. If there are varicosities and if it has extended up to the vulva or inner side of the vagina, then the vaginal delivery may be dangerous because she might bleed torrentially. If there is swelling or excessive edema of the lower limbs, we should also suspect if she has preeclampsia. Pelvic examination. Routine pelvic examination is not necessary, but there are certain circumstances in which a vaginal examination is necessary. In most cases, a speculum examination is all that is needed. Like in conditions of excessive or offensive discharge per vaginum, if there is vaginal bleeding in the absence of placenta previa, in order to perform a cervical screening, in order to confirm the potential rupture of membrane. There are certain conditions where the digital examination is contraindicated, like when there is bleeding in case of known placenta previa or vaginal bleeding when the placental site is unknown. Repeated vaginal examination is contraindicated if there is preterm pre-labor rupture of membranes or pre-labor rupture of membranes because repeated examination increases risk of ascending infections. These are the different sources of information where I've taken or made my slides from. Never. Thank you very much.